Welcome to this week's edition of Ask an MS Expert. I'm John Strum, and I'm the host of the Real Talk MS podcast. Each week, Real Talk MS reaches thousands of people in more than 90 countries around the world with the news that people affected by MS need to know. My wife, Jean, lived with progressive MS for 23 years, so I've had a front row seat experiencing all the ways that MS can impact a family. Currently, I'm a member of the International Progressive MS Alliance Scientific Steering Committee. I'm a district activist leader and trustee for the National MS Society, and I chair the Society's California Government Relations Advisory Committee. As we get underway, I'd like to acknowledge and thank today's premier national sponsor, EMD Serono. Support from MS community partners helps the National MS Society reach its goal of providing up-to-date information and support through programs like Ask an MS Expert. And I want to thank all of you who are joining us on GoToWebinar, Facebook Live, and YouTube Live. The MS Society's Ask an MS Expert webcast is designed to connect you with MS experts who are ready to answer your questions on the topics that impact people affected by MS every day. So as I chat with our experts today, please feel free to post your questions on Facebook and YouTube, or type them into the question box if you're joining us on GoToWebinar. We'll try to answer as many of your questions as we can during the Q&A portion of today's program. Everyone's MS journey is unique and unpredictable. Some people living with MS experience a gradual progression of symptoms that can impact a broad range of functions and abilities, while others experience ongoing disease progression right from the beginning. Today, we're talking about effective strategies and treatment options for living well with progressive MS, and we'll look at some of the promising advancements in progressive MS research. Joining me in our discussion today are Dr. Daniel Ontaneda and Dr. Falashade Fakaladay. Dr. Ontaneda is a past recipient of a Sylvia Lowry National MS Society Clinical Fellowship Award. He's an associate professor of neurology at the Cleveland Clinic Lerner College of Medicine of Case Western Reserve University and a staff member at the Cleveland Clinic Neurological Institute's Mellon Center for Multiple Sclerosis. Dr. Ontaneda is also a member of the Executive Steering Committee for the North American Imaging and Multiple Sclerosis Cooperative and a member of the Multiple Sclerosis Functional Composite Task Force. Dr. Fakaladay is a physical therapist with expertise in neurorehabilitation. She's currently an assistant professor in the School of Rehabilitation Therapy at Queen's University in Ontario, Canada, and her research focuses on developing, evaluating, and implementing family-based health interventions for people with advanced MS and their family caregivers. I'd like to begin our discussion by welcoming Dr. Ontaneda. Thank you for being with us today.
Hello, John. How are you? Thanks so much for having me on. It's a true pleasure to talk to you. And thanks to the Society also for the invitation.
I'm doing well, and we appreciate you being with us today. You know, primary progressive MS affects somewhere between 10 and 15% of the people who are diagnosed with MS. And being diagnosed with primary progressive MS can feel confusing and even overwhelming, leaving people to wonder what their future is going to look like. Dr. Ontaneda, can you explain what primary progressive MS is and how it's different from other forms of MS?
Yeah, thanks so much for the question, John. So primary progressive MS, like you said, is a subtype of MS or course of MS. And we think that it affects approximately 10 to 20% of patients from the start of their disease. Primary progressive MS is a little bit different than relapsing-remitting MS, which is the most common form. 90% of patients start with relapsing-remitting. And the main difference is how patients accumulate their disability. In relapsing-remitting MS, patients have attacks, and they accumulate disability because they do not completely recover from those attacks. Primary progressive MS is a little bit different in the sense that they're accumulating disability not really related to attacks, but on a very slow trajectory. patients many times feel like they're slowly worsening. This is something that might be initially, especially, they might not even notice the worsening on a day-to-day basis. But for example, if they ask themselves, how am I doing today to compare to how I was doing 6 months ago? They've noticed in the steady progressive decline. That's where the name comes from. And we think that primary progressive MS and relapsing MS are the same disease, but in a sense, a little bit different in the pattern of how patients accumulate that disability. So I kind of describe it as the difference between, if you can imagine, going up, perhaps some stairs where the stairs are unequal in size. And in primary progressive, it's more like a conveyor belt that is slowly, going up. Patients notice that worsening on a day-to-day basis.
Well, how is primary progressive MS diagnosed? Are there specific criteria that are used to diagnose someone with primary progressive MS?
Yeah, I think the first thing to mention is that on average, it takes longer to diagnose a patient with primary progressive MS as compared to relapsing MS. So many times it's not as clear from the get-go. And this is because, a relapsing-remitting patient might have an attack, they might notice it. It's very noticeable. It's something that you can feel from the get-go, and they'll typically go to the neurologist. Because there's this insidious onset with primary progressive MS, typically the diagnosis takes a little bit longer. It takes a little bit longer for patients to recognize it. And then once recognized, it takes patients a little bit longer to get to the neurologist, and it takes the neurologist a little bit longer to actually figure it out. And to answer your question, yes, there are specific diagnostic criteria that have been designed to capture primary progressive MS. And what the diagnostic criteria mean is just basically a checkbox mechanism to say what people actually have MS or not based on a certain number of criteria. In the case of primary progressive MS, people need to have at least a year of progressive accumulation of neurological disability, and that's worsening in any sphere of neurology: weakness, numbness, tingling, vision loss, bladder, bowel dysfunction, whatever it might be, but it has to be there for a year, and it has to be progressively worsening. And then the second thing they need to have is they need to have either lesions on their brain that look like MS lesions, lesions in their spinal cord that look like MS lesions, or the presence of specific biomarkers in the cerebrospinal fluid. Many of you will recognize those called oligoclonal bands, presence of those in the spinal fluid that indicate with a greater certainty that a person has primary progressive MS. I will say that primary progressive MS is a little trickier to diagnose than relapsing-remitting MS because there's a variety of neurological conditions that are also progressive. And therefore, we generally take extra caution with diagnosing. And I would say on average, we use spinal fluid a little bit more when we're making a diagnosis of primary progressive MS.
Anna wrote in saying her doctor told her she has active progressive MS, and she didn't understand what he meant. What's the difference between active and inactive progressive MS?
Yeah, that's a great question. And it's something that comes up often. I think in the past, we had kind of binned MS into categories of progressive and relapsing, and that's about it. And we knew that progressive MS was related to the presence of that insidious, very slow worsening of disability, and relapsing MS was punctuated by more brain lesions, more attacks, or clinical relapses. And, this distinction was a little bit like there was a wall between the two types of MS. And I think what we realized is that MS is, as a biological variable, has basically a distribution that is, some people will have a feeling that sounds a little bit more like progressive MS. Some people will be very much like just relapsing MS and attacks. But the truth is that both conditions can coexist. And so I always tell people, it's not that you have all progressive MS or all relapsing. It's always going to be a little bit mix of these two different, areas that might exist. On the one side, progressive worsening of neurological function. On the other side, presence of relapses or attacks, which are more typical in relapsing MS, and presence of new lesions. And so when somebody is called progressive with activity, what we mean is it's a person who has that slow accumulation, but might have, in addition to that, might have an attack. Or in addition to that, might have some activity on their brain MRI in the form of either new lesions or new active lesions, lesions that actually, when you give a patient contrast, will brighten up. That's kind of what we typically define as active lesions. And so I think what the question illustrates is that it's not an all or nothing. And as what you guys can see on the slide is kind of the way we think of primary progressive now. We know that patients have that, slow accumulation of disability. And then if we say it's inactive, it means that, patients, many times don't have new lesions. They don't have relapses. And then if we call them active, it's because they have lesions or they don't, or they have attacks or they don't, and that's what we would call activity. And then aside from that, what we also try to do is we say, well, a person might progress with MS, and then they might be stable for a while. And that's something that we would call progressive MS that's stable or doesn't have a progression, right? And so I think what we're trying to do now is basically describe patients a little bit better, try to describe them closer to what biology identifies.
Are there specific factors that might contribute to disease progression in MS?
Yeah, absolutely. We know that there's a lot of factors that we think might alter how patients progress through their disease. And specifically, one of the things that we've looked at is kind of the demographic characteristics of patients. So we know that, for example, primary progressive MS tends to affect men more in a less lopsided way than relapsing MS. Relapsing MS primarily affects women. 3-to-1 is the typical ratio. In primary progressive MS, it's a little bit more even. The percentage of males versus females evens out. And we know that males typically who have primary progressive MS tend to actually progress a little bit quicker. Then there's other factors, such as, for example, race. We know that, for example, patients who are Black, African Americans, tend to have greater rates of progression. There is some emerging data that also indicates that perhaps Hispanic and Latino patients might also have a slightly more severe course. And then the other thing that we look at a lot is what the MRI looks like. And when an MRI shows very few lesions, we know that patients are less likely to have, accumulation of disability. And that's true in relapsing-remitting MS. It's also true in primary progressive MS. But in primary progressive MS, it's interesting because patients in general are described as having a relative paucity or a fewer number of brain lesions as compared to a relapsing patient. So then people ask the question, well, if it's not the lesions in the brain, what's driving that progressive worsening? And we think a lot of that boils down to the presence of lesions in the spinal cord. And so presence of lesions in the spinal cord in any type of MS likely indicates that the disease is going to be a little bit more severe, and there's probably going to be a little bit more progression.
When it comes to symptoms and severity, people living with primary progressive MS may experience a different MS journey. And for them, proactive symptom management is really key to being healthy, staying productive, and enhancing their overall quality of life. Doctor, what are some common symptoms that people living with progressive MS might experience?
Yeah, so like we talked about before, symptoms of progressive MS can be symptoms that really are affecting any part of the nervous system, specifically the brain and the spinal cord. Probably what we see most in primary progressive MS is what we consider, as neurologists, we call a progressive myelopathy. And what that means is that it's progressive degeneration in the spinal cord. Patients many times will present with weakness, which worsens over time. That weakness initially might mean that it might be difficult to lift your leg, or it might be difficult to lift your arm. But over time, if that progression is sustained, it results in some difficulty with your gait or with your ability to walk. So that's kind of one of the biggest things. And that's the thing that we probably worry about most with our patients is their motor function and their ability to walk and to get around. Hand in hand with that, very common in spinal cord, is spasticity. So as people become weak, they'll also notice tightening in their legs and in their arms, associated sometimes with spasms. It's not uncommon for patients also to have bladder and bowel dysfunction of different types. In an extreme case, that would be loss of a function of the bladder or bowel, or perhaps just symptoms that might be somewhat bothersome. And then there's also sensory symptoms, so numbness, tingling, and that can include pain, is something that we see quite commonly. Other symptoms include lack of coordination, balance, and difficulty with vision as well. A little bit less common in primary progressive MS as compared to relapsing, but also can definitely be present. Perhaps the most universally described symptom of MS patients is fatigue. It's one of these symptoms that is present in almost all patients I talk to. It's rated as one of the most bothersome symptoms, and it's really hard for us to kind of document that on a neurological exam. We kind of, many times people have considered it kind of one of the silent symptoms of MS that really affects quality of life a lot, but perhaps as neurologists, it's more difficult for us to measure. And then I kind of round it out saying that, one of the other big categories of involvement in primary progressive MS is cognitive involvement. That's difficulties with memory, concentration, multitasking. And that can play a significant toll on patients and also can really interfere with work productivity. Typically, we say that that's one of the things that the neurologist should be screening for and proactively looking for, because many times it can go by the wayside, especially in progressive MS patients where that deterioration may be very slow and gradual.
Depression is a common symptom among people living with progressive MS, and I'm wondering, is depression among people with primary progressive MS an MS symptom itself, or do people with primary progressive MS develop depression because they're living with a more aggressive form of MS?
Yeah, it's a tricky one, isn't it? What we think is that there's something about MS that produces depression. So many studies have shown that when you look at patients who have disabilities from other causes, that is not MS, for the same amount of physical or cognitive disability a patient might have, if you match for that, the MS patient on average will be more depressed. Okay, so we don't think that it's just that their MS is more severe and therefore they're more depressed. We think that depression is an integral part of what MS is. And that's why I many times tell my patients, if you're feeling depressed, if you're feeling down, don't feel like it's that you're not trying hard enough. Don't feel like this is something that you're doing. This is part of what MS is, and it's part of the things that we need to kind of tackle with treatment, both with treatment that's non-pharmacological, so not medications, but actually stuff like therapy, counseling, and also medications when needed.
So it sounds like when it comes to depression, early diagnosing and treating for someone living with primary progressive MS is somewhat important.
Absolutely. I think that one of the recommendations that the AAN makes, the American Academy of Neurology, and something that we've recognized, is that patients should be screened for the presence of depression at every single clinic visit they come into. We do that with validated scales, but it's as easy as asking a patient, how is your mood? How has your mood been since your last visit? I think if we don't identify and if we don't promptly diagnose, we really won't treat it. And we know that depression, being one of the cardinal symptoms of MS, actually is one of the things that affects quality of life the most. So it's one of those things that we like to tackle head on. We talk to all our patients about depression from the get-go, so that they're vigilant, so that their family members are vigilant about it, and we're very proactive when it comes to treating it.
For people living with primary progressive MS, preventive care strategies are an important part of an overall optimal care plan. Can you share some preventive care strategies for someone who's living with primary progressive MS?
Yeah, absolutely. So we know that part of what we're trying to do with MS is take care of the brain. I think all of us have to take care of our brains. But I think that for the patient with primary progressive MS, it becomes especially important to take care of your brain. And there's a lot of things that patients can do that are not really things that are done by the neurologist. These are things that patients can do on their own. I think the first thing that I typically talk to my patients about is making sure that, we try to optimize their medical issues as much as possible. So making sure that the typical, risk factors that we have for heart disease and for stroke, we think those also play a significant role in MS. These include high blood pressure, cholesterol, diabetes, and smoking. These are the types of things that, we can actually manage them. The neurologist can manage them, or the patient can keep an eye on it. Smoking cessation programs can be started. So one is kind of controlling those vascular risk factors. Studies indicate that those people who have well-controlled vascular risk factors, who don't have vascular risk factors, do better than the patients who carry those risk factors. So that's one thing. I think the second thing is one that we all have to do, which is a good amount of exercise. We know that exercise promotes repair of the brain. We think that one of the ways it does that is through promoting remyelination. And so it's important for patients to continue some form of physical activity. I think, for the patient who has milder MS, that's quite easy. They're going to pretty much be practicing exercise as any person would. I think with the patient who has a little bit more of disability, we have to be a little bit more proactive about thinking about ways for people to exercise. For example, for my patients who have a lot of difficulty with their walking or at risk of falling, one of the ways they can exercise is, for example, on devices where they're stable, in water, for example, doing aquatherapy is a great example. And we recommend all our patients get, at least, 2 to 3 days a week, 30 or minutes of exercise. The more you can do, the better, but we recommend they do that. I think one of the other things we recommend is a healthy diet. There's a lot of diets out there, and there's, a lot of different approaches that have been taken. We tell people that, our general suggestion is do a heart-healthy diet, Mediterranean diet, make sure that half your plate are fruits and vegetables, try to cut down on red meats, try to cut down on any processed type of food, simple sugars, try to cut down on those. If people approach me many times, I want to do a paleo diet, or I want to do a ketogenic diet, I tell them that's great. Any diet you find will probably make you healthier, and it's probably going to help your MS. I don't recommend specific diets other than, a heart-healthy Mediterranean type diet, because everybody has to find kind of what works best, for their diet. And then third, I think, one of the other things that I talk to my patients a lot with progressive MS is making sure that, their vitamin D levels are repleted. That's something that we know vitamin D is a risk factor for MS, and therefore making sure that their vitamin D levels are repleted, especially this time of year as we're exiting winter. Our vitamin D levels, all of us will probably have low vitamin D levels. So making sure that those are up to par makes sense. And then finally, keeping stress away, I think is really important. Stress plays a toll on the immune system, plays a toll on how we, experience symptoms. And so it's really important to make sure that we kind of try to reduce stress. That kind of goes hand in hand with treating of depression. And many times I tell my patients, every single patient we see here at the Mellon Center, we're lucky because we've got a great psychology team that supports us with counseling. I send every single one of my patients to psychology to help with mindfulness techniques, for relaxation techniques, stuff that you can do on a day-to-day basis to keep stress and anxiety away.
I want to take just a moment to welcome those of you who've continued to join us on GoToWebinar, Facebook Live, and YouTube Live. Please let us know what's on your mind. Post your comments and questions on Facebook and YouTube, or type them into the question box if you're joining us on GoToWebinar. MS Navigators are also online throughout today's program, answering questions and connecting you with resources. Our Ask an MS Expert live event takes place at this same time every Friday. So please help us make sure that everyone knows about it by sharing news about the webcast with your family, your friends, and on all your social media channels. Optimal care for a person living with primary progressive MS involves several strategies that are integrated into a coordinated treatment plan delivered by a multidisciplinary team. Dr. Antoneta, which doctors and other specialists comprise an ideal care team for someone living with primary progressive MS?
Yeah, great. So we've already mentioned a couple of them, so we got kind of a foot ahead here. But I think, the care team for MS has to be a multidisciplinary care team. And that means, it's not just one person taking care of these patients. I think on the one side, you have your neurology providers, and those include neurologists, nurse practitioners, physician assistants, and also nurses, MS nurses. And they are the ones that are, kind of directing the care, many times doing the medication management. Aside from that, one of the people that we work most with is with our physical therapy colleagues, and we're going to hear more about that in today's session. So I'm not going to steal that person's thunder, but that's an integral part of what we do. We also kind of liaise with physical medicine and rehabilitation, occupational therapist, and then finally speech therapist for when patients have difficulty with swallowing or actually with speech issues are really important. We at the Mellon Center are strong believers in making sure that, patients get the psychological support they need. And so part of our team includes our neuropsychology specialists, includes our psychiatry specialists as well, because those are the people that might need to prescribe a medication if we have a significant problem with depression or anxiety. We also work closely with urology because many times the bladder bowel issues are, especially the bladder issues, are a little bit more than the typical neurologist can do. Many times patient will need specific testing of bladder function, and so we try to keep our urologists involved as well. Then we also have, in terms of bowel disorders, we work sometimes with GI specialists to make sure that stuff like constipation is taken care of and is affected adequately. And then, we typically have a separate team, which is a spasticity team, which dedicates its time to spasticity itself. And that includes, for the more advanced cases, treatment using Botox or treatment using baclofen pumps, stuff like that. I think that's important to have kind of also in your armamentarium. And then finally, I think social work is super important. We're lucky to have a social worker that's embedded in our center. And I think it helps guide patients through issues with disability, issues with paperwork. How do you deal with work related to MS and work related issues? There's a lot of that stuff that needs to be done on a day-to-day basis, and I think a social worker is great to take care of that. So basically, a large group of people, across multiple specialties, I think is the ideal scenario to take care of a patient with progressive MS.
For people living with primary progressive MS, having a treatment plan in place is critical. What are some of the key recommendations for managing primary progressive MS?
Yeah, a great question, John. I think one thing is, once you've established your care with your neurology team and your MS team about the care, I think, one of the main things we try to do is we try to set forth a plan. Well, what do we want to do? What are the goals we want to achieve? And I think those are kind of divided, in my mind, at least into kind of two main goals. One goal is the goal of what treatments should we be using? What disease-modifying medication should we be using? And that's something that typically has more to do with a neurologist, with a nurse practitioner, with a physician assistant that are kind of directing that care. We do, and we make many of those decisions based also on MRI. So MRI becomes a large component of that. And then the second big thing is, well, how do we make sure that we improve, your quality of life? And that includes symptomatic care. And many times what I do with my primary progressive MS patients is, let's sit down, let's think about what are the symptoms that are bothering you the most and how are we going to tackle them? And we try to tackle them in order of, which ones are the ones that are bothering you the most, start with those, and, chisel away at the problems. We're not huge fans of adding medications. I think for a lot of patients, they feel like, being on too many medications sometimes run into side effect. So what we try to do is we try to be strategic about where we use medications, where they might be needed, and what other things can we do that are outside of medications that might help quality of life. So I think we put in a plan that we say, these are our goals, this is what we want to do, these are the symptoms we want to try to improve or alleviate, these are the long-term goals that we hope to do with disease modification, and then we see patients on a regular basis. Every 3 months, every 6 months, depending on the clinical scenario. And we reassess where are our goals at each of those visits. We do an MRI to see if we're meeting our goals in terms of disease-modifying medications. We reevaluate the symptomatic issues to make sure that we reprioritize what might be most important for the patient at every individual visit. And I think that it's key to make sure that there's good communication between the neurologist, the different care team members, and importantly, the patient and the family, the caregivers, the caretakers. What we try to do is we make sure that everybody's voice is heard, and we try to make the center of all that the person who has MS.
You mentioned medications a moment ago. What medications are available today to treat primary progressive MS?
Yeah, so currently there's only one medication that's FDA approved to treat primary progressive MS, and that medication is a medication called ocrelizumab. It's a therapy that affects B cells. And while we have over 12.5 medications for treating relapsing MS, the number of medications that we have for progressive MS is a little bit smaller. Currently, we only have one medication. But this harks back to the question that we asked about, what is the definition of activity? And so we know these medications, the disease-modifying medications for MS, these medications work on lesions and when we see inflammation in the brain. And inflammation in the brain is manifested as new lesions or attacks clinically. And typically, what we think is that if a person is accumulating new lesions, and if they're having attacks, even if we've qualified them as progressive MS, we still think they might derive benefit from these therapies. And so, our most used medication in primary progressive MS currently is ocrelizumab. It's a little bit difficult in terms of, stating what your goal is for the medication because, in relapsing MS, it's easy. We say, we're going to get rid of relapses, we're going to get rid of attacks, and that's what we're going to do. With primary progressive MS, it's harder because what we're saying is that what we're trying to do with these medications is slow the progression of the disease, slow the accumulation. In some cases, patients feel that they start the medication and they're stable. That's an ideal scenario. Then it becomes easy. We say, we'll continue this until you've noticed any changes, and stability is what we want. But I think the more common scenario is not stability. The more common scenario is that patients continue to notice some worsening. And so we have to do a good job about making sure that both the patient and the neurologist and the measures we're capturing reflect that we're trying to capture if the medication is actually slowing down the worsening compared to when you were before the medication. It's really hard for patients to sometimes, try to, especially when they're progressing very slowly, to capture that. And it's sometimes difficult when you're getting an infusion every month and you don't notice an improvement necessarily, right? So what I tell many times to patients, what I talk about is, imagine if, we take, you, John, say you had MS, and we clone you, we give one John the medication, and we give one John, we don't give him a medication, and we look at them 5 years down the road. The idea is that the John that took the medication is going to look a whole lot better. Now, on a day-to-day basis, he might not notice that. But at the end of those 5 years, there will be a considerable difference.
That's a great explanation of the importance of disease-modifying therapy, even when you're not seeing that immediate improvement or even relative improvement at the time. Given the fact that there is one approved disease-modifying therapy for primary progressive MS, what are some of the barriers that have limited progress in progressive MS research?
Yeah, another great question. I mean, I think the truth is that progressive MS is related to a lot of different things. And, I think progressive MS is, part of it is inflammation and part of it is neurodegeneration. And this is kind of a fancy word that just means that over time, tissue will degenerate. And when there's lesional tissue, we think that it degenerates quicker. And there's a lot of different things that come into that degeneration. So we think that on the one side, inflammation probably promotes degeneration. On the other side, we think that actually mitochondria might not be working perfectly in MS, and that promotes degeneration. On the other side, we think that cells run out of energy. The brain cells that have lesions in them, they run out of energy, and therefore, they will start to degenerate. We think that also there's these products of oxidation that accumulate in the brain and spinal cords of MS patients, particularly progressive MS patients, which causes degeneration. So, I've just listed out a couple of the mechanisms of degeneration that drives progressive MS. And I think relapsing MS is easy to treat because it's mainly inflammation. So if you treat with an anti-inflammatory, it's easy. You've got a single thing that you're treating. When you're treating primary progressive MS, it's probably not just a single thing. It's probably not just inflammation. It's probably inflammation plus other things. And so understanding that it's a much more complex process really helps us understand why it is so much more difficult to treat. I think that, for many patients, they experience this because they feel like they don't have the right medications. And, I always, when I meet with my primary progressive patients, they always tell me, doctor, when is something better coming out for this disease? And, there's a lot of research that is going on that is trying to explain better what these processes of this degeneration is. And what we're doing now is, as we improve our understanding of these concepts, is we're going into different treatments for these specific pathways. And hopefully, the idea is that we can develop therapies along each one of those pathways that might help individuals with progressive MS.
The International Progressive MS Alliance represents a first-of-its-kind global response to solving progressive MS. The Alliance has catalyzed MS organizations, leading researchers, and people affected by progressive MS from around the world to address the challenges of progressive MS through a coordinated, collaborative approach to research. Can you share how the Alliance is fueling research on progressive MS and tell us how people can get involved?
Yeah, absolutely. So, I'd say that the Progressive MS Alliance, as you described, is a network of investigators an investigator of foundations and bodies of funding that is working to try to, make sure that that gap that we have, that we can't treat progressive MS, is sealed. And I think that, they're doing it in several ways. On the one end, they're funding a lot of research to better understand what drives that progression. So those things that I just described right now, those are the types of experiments we need to do to better understand exactly what's going on in the disease process itself. I think the second thing that the Progressive MS Alliance is doing is that it's trying to accelerate what we call our clinical trials. Clinical trials are studies where we actually examine medications and their efficacy and how well they work. And I think that, and we know how to do that in relapsing MS. We don't know how to do that as well in primary progressive MS. And so one of the big pushes is actually to develop tools for clinical trials, to make the design of clinical trials better, to make the implementation of clinical trials better, to make the efficiency of clinical trials better. So we don't want to have to run huge trials to make, to get a medication that doesn't work. We prefer to run smaller trials in a fewer number of patients and screen and make sure that they can work. And so, this is not only true for medications that prevent worsening of disability, but now what we're working on is actually medications that might rebuild myelin, medications that might repair function. So, we've gone to saying we want to flatten the curve to actually making the bar a little bit higher. What we want to try to do is actually improve MS patients using a medication. And so that's kind of part of the push that we're doing for progressive MS trials. And then finally, there's a large emphasis on making sure that we actually improve the well-being or how patients feel with MS. And I think that, that's one of the important things that, I think that as neurologists, perhaps, and researchers, we haven't thought as sufficiently about is how can we improve function on a day-to-day basis? How can we improve well-being on a day-to-day basis? And I think the Progressive MS Alliance is actually producing a lot of research in that area, and research that will actually help us answer these questions. And then finally, how to get involved with Progressive MS Alliance. I'd recommend people to visit the Progressive Alliance website, and I'm sure we can share that perhaps in the chat box. It's progressivemsalliance.org. And there specifically you can sign up, you can contact your neurologist, ask about possibilities for research, and try to engage in a larger community of progressive MS. This is present all over the world, like you said, John. And I think we want our patients and people with MS to be partners in trying to get solutions for progressive MS.
Well, thank you, Dr. Antoneta. We're going to circle back with you in just a few minutes. Now I'd like to continue our discussion with Dr. Facalati. Welcome. Thanks for being with us today.
Hello, Jen. I'm very happy to be here. Thanks for having me.
Rehabilitation is an essential component of comprehensive care for people who are living with primary progressive MS. It focuses on maintaining optimal function and improving function that may have been changed or even lost. Doctor, what is the goal of rehabilitation for someone living with primary progressive MS?
Thank you very much for that question, John. So because we know that MS is such a heterogeneous disease, and as Dr. Antoneta mentioned earlier, there's a variety of symptoms that people with progressive MS might experience. And so rehabilitation for this population tends to be very tailored and individualized based on a comprehensive assessment of the unique needs. And so the goals might be different depending on the needs or the symptoms that the patient presents with. So for instance, when we start to think about modifiable impairments like weakness, like spasticity, like pain, the focus might be on improving those outcomes where they're identified as main contributors of functional limitations. So we really work hard at things like strengthening, things like flexibility, and things like strategies for pain reduction. And where we see that changes are not possible or they're limited changes, so for instance, people that have a more complicated or complex disease process, then we work on teaching new skills. We work on teaching compensatory strategies that enable them to still be able to participate in activities that are meaningful to them. We also work on things like assessment and provision of adaptive equipment and things like modifying the environment to ensure that people have an increased sense of competence and they can adapt and navigate their day-to-day life. Dr. Antinata mentioned that a huge component of symptom that is experienced by this population is balance issues. And so that's a key focus of rehabilitation because we know that impaired balance is an important contributor to mobility difficulties. And we've also now come to know that balance impairment is associated with falls and fear of falling and activity curtailment. And what that means is that when people start to experience balance issues, then they start to fall more often. And as they fall more often, they start to have a fear of falling. And so they reduce the activity that they would perform because of this fear. And all of that together leads to a downward spiral of immobility, of deconditioning, of faster accumulation of disability. And so we play a key role as physiotherapists, as occupational therapists in optimizing safe mobility, whether that's by maintaining more physical activity or teaching fall prevention strategies or fall management program. So we do a lot of that. The other thing that's huge that we work with is fatigue management and teaching people how to manage energy and how to strategies for combating the impact of fatigue on their lives and making sure that they're still able to participate in meaningful activities. More recently, we've started to really understand the importance of health promotion, and Dr. Antinata alluded to that, like that we know that the rates of comorbidities like hypertension, like diabetes, much higher among people with MS than the general population. And so we've started to focus on rehabilitation in health promotion and really encouraging a healthy lifestyle. And we do this by incorporating behavioral strategies and teaching people how to, whether it's initiating physical activity or whether it's maintaining physical activity, to just ensure that they're not stagnant, they're progressing in this daily activities or in this health behaviors that have such a huge impact on quality of life. So if I were to sum up what the overall goal of rehab would be, it is to promote function within that limit, understanding that sometimes function might not be the way it was before the diagnosis of MS or before progression in disability, but to maintain function within the limits that we can, to really promote and encourage participation in meaningful activities and to improve overall quality of life. So those would be some of the key goals that we work on achieving in rehabilitation.
And who is part of the rehabilitation team?
So because of the wide variety of symptoms that are experienced by these people, again, the composition of the rehab team is typically driven by the needs of the patients. So that could include physical therapists who will work on movement and functioning and things like strengthening, things like mobility and balance and postural training and all of that. We have OTs who would work on helping people with everyday skills that are needed for participation, whether that be at home, at work, at play, whatever it is that they're doing, that the being able to meaningfully participate in those activities. OTs also really provide a lot of support in terms of assistive technology to increase access and independence in functional tasks. So whether that's modifying the environment or teaching strategies to ensure that the energy that's being used for those activities are optimal and people are still able to engage. The rehab team can also involve, and Dr. Antinata alluded to this earlier, speech-language pathologists who will work on speech and swallowing problems that results from impaired muscle control. And sometimes the speech-language pathologists will also be involved when there is cognitive dysfunction, particularly when it starts to affect communication. We also sometimes would involve the social worker who would help with referring to resources, whether that's resources about insurance or resources about long-term care options. So those are some of the key members who play a part in this multidisciplinary rehab team that helps to manage multiple sclerosis.
The National MS Society's recently published guidelines specify that exercise and lifestyle physical activity are beneficial and safe for all people living with MS, regardless of their ability level. Doctor, what are some of the benefits people with primary progressive MS experience when they incorporate lifestyle physical activity and exercise into their daily routine?
So unfortunately, we know a lot more about the benefits of exercise training, particularly in more relapsing causes, but we don't know as much about what happens in terms of exercise training and the benefits in progressive MS. But we have a few studies, we have preliminary evidence that suggests that when people incorporate both lifestyle and more structured exercise training into their daily activities, there's some evidence showing that cardiorespiratory fitness is improved. So things like aerobic conditioning, things like endurance start to improve. We also have evidence suggesting that muscular fitness, so things like improved muscle strength, that tends to improve also with physical activity and exercise training. There's a small subset of studies starting to show improvement when people with progressive MS start to engage in physical activity, particularly for outcomes like fatigue and quality of life. Where our evidence tends to be less clear is when we start to look at effects on things like functional and symptomatic outcomes like balance and falls and mobility and things like pain. There doesn't seem to be a detrimental effect at this time, so I would still encourage and recommend people to be active. So that's what the evidence is suggesting, but more on the clinical side, we do see improvement and we do see real distinct improvement when people start to participate in physical activity and when they start to exercise. But what I think that we need to do better about is capturing those outcomes. So we see the outcomes in the clinic, but we haven't done a very good job of capturing those or designing studies that really tell us how these outcomes or the mechanisms behind how exercise promotes these outcomes. And we're starting to look at that, but we aren't quite there yet. So we don't know as much as we should know, but this is very exciting times because there are huge studies going on right now, sponsored by a lot of the push by the Progressive MS Alliance, bringing this to the forefront that we need to be looking at some of these outcomes in people with progressive MS.
What's the best type of exercise or activity for people with advanced MS, and how much activity do they need?
So that's a great question, and that's a question that we get asked a lot of the times. And again, the evidence out there is not conclusive yet as to the type of dosage of exercise in terms of what the best type is, what the frequency is, and what the most effective parameters for exercise prescription is in this population. But there are studies that are starting to look at effects of adaptive modalities, things like the recumbent stepper, the arm ergometer, so those are the ones that cycle with the arms, or things like the functional electrical stimulation cycles. And we're starting to see improvement with people in terms of mobility outcomes, particularly for people who use these modalities, but with the recognition that not all people will have access to these kinds of modalities. So it's being able to find activities that are enjoyable for you and find activities that can be adapted, and just thinking outside the box of what might be doable and what might be interesting to start to explore. In terms of how much physical activity is needed, so the exercise and physical activity guidelines that was recently published last year says that people who have more advanced MS, the recommendation is up to 10 to 20 minutes daily of physical activity, 3 to 7 times per week. But the trick or the important part of this is that exercise has to be something that is an individualized and gradual approach. So for someone who hasn't exercised before, we're not asking you to go start running a marathon, for instance. It has to be very individualized. It has to be you listening to your body and trying to navigate what's doable, and then gradually increasing that. And so whether that is independent activity or whether that's assisted activity, important thing is to be consistently accumulating activity and incorporating a wide variety of exercise. So for people with progressive MS, we're thinking things like breathing exercises for people who are more advanced in the disability spectrum. Flexibility exercises are also very key in managing, improving range of motion, in managing spasticity. We also start to focus on upper and lower extremities. So whether that is strengthening exercises or whether that's, again, flexibility, and exercises that targets the core. So both our abdominals and our back muscles, and making sure that those are activated with our exercises.
We're living in a digital world that's provided new ways to deliver care and even tools to help people stay independent longer. I'm wondering, what can you tell us about your experience using Tele-rehabilitation for people living with MS?
So I think that telerehabilitation has become a lot more important now in the context of COVID, and we've started to really look at very innovative ways of using, whether that's using video conference or other web-based resources. And it's been very interesting because traditionally there was some exercises, for instance, if I was training someone, balance training, I wouldn't typically do that. I wouldn't think that that would be possible to do via telerehabilitation, but there are now studies starting to look at how we can incorporate and support some of these therapeutic exercises using whether that's web-based, whether that's video conferencing, or other options that are very interesting that are coming out now. I know that there's huge studies coming out of the US, of UK, even Canada, that's looking at some of this tele-exercise options, and we're starting to generate knowledge and continuing to understand how we can both support initiation of physical activity and continue to support that maintenance long term. And I think it's important to just find options. So not to think too complicated about it, whether that's using Zoom as an option or finding what's available in the community. There's a lot of changes that have happened because of COVID. Therapists are changing and are being able to now adapt some programs that were traditionally delivered face-to-face. So it's being able to find what's available in the community and how you can plug into that will be key as we move forward and generate that evidence to support telerehabilitation for people living with progressive MS.
Well, I'd like to invite Dr. Antoneta to join us again. You both shared some really important information about primary progressive MS today, and now I'd like to ask each of you to share your top 3 takeaways that you'd like our audience to remember. And Dr. Facolati, let's start with you.
So I think the first key that I want to really emphasize is many times when we talk about rehabilitation, we think it's a one-time process, but it's not really. And being able to plug into that, and once you have a therapist that you've identified that you work well with, that works well with you, that has that MS specific knowledge and expertise that is important for your health, stick with that and continue to use and continue to leverage that relationship will be one. The next thing I want to emphasize is this idea of exercise and physical activity. And many times people get overwhelmed with the idea that it has to be a structured, planned exercise program. But now we're starting to realize that things like lifestyle physical activity, so things that we do in our every day-to-day life, we can modify those to begin to get benefits out of them. So there's more research that is showing that even light physical activity has benefits. And so I think the key takeaway message from that is that some activity is better than none. And so whether you will want to start very, very small, and what that means might be just doing some sit to stand exercises, for instance, or whether you want to think more about how to adapt some of the things that you're already doing, just taking it a notch more to be active. Those are things that we have to consider, and those are things that are very helpful in promoting overall well-being and quality of life.
And Dr. Antoneta, what would you say are your top 3 takeaways today?
Yeah, so I think top 3 takeaways is one, when you talk to a neurologist, make sure that you clarify that, what the treatment plan is in terms of, disease modifying medication on the one end, and on the other end, what's the plan for the symptomatic medication. Two, make sure you've got, a wide MS team that includes specialists like Dr. Facolade just talked about, that you have the people around you that you need. And I would say third, I think, research is super important. And I think that research is important for patients, and I think patients are the ones that have to drive it. People with MS have to drive the research we're doing. So, I'd encourage everybody, visit the Progressive MS Alliance website, talk to your neurology care provider about how you can participate in clinical trials, because, if we're going to figure this out, it's the patients that are going to figure it out with us. So push for research.
Well, thanks to all of you who submitted your questions, and thanks to you both, Dr. Facolade and Dr. Antoneda, for being with us today.
Thank you so much, John.
Thank you so much, John.
I think that one of the best things that anyone can do for themselves, especially during these uncertain times, is to make sure that the information they're getting is credible and reliable. So we'd like to share some resources with you. And these are the resources that you can count on to be current and to be credible. I want to remind you that the National MS Society's MS Navigator team is your best partner when it comes to connecting you to the very best information and resources on living with MS. You can reach an MS Navigator by phone, email, or through the Society's website by chat. And I'll also remind you that the MS Society brings people together through peer connection groups like self-help groups, the MS Friends Helpline and Paired Program, and the National MS Society Facebook community. To learn more, please visit the Society's website at nationalmssociety.org/connections programs. For more information about primary progressive MS, please visit the National MS Society's website at nationalmssociety.org. And to learn more about the International Progressive MS Alliance, you can visit them at progressivemsalliance.org. Every week on the Real Talk MS podcast, I continue the conversation that we start here. So I hope you'll take a few minutes and give Real Talk MS a listen. You'll find the Real Talk MS podcast at realtalkms.com, Apple Podcasts, Google Podcasts, Spotify, Amazon Music, or wherever you find your favorite podcasts. Walk MS 2021 is coming, and this year, Walk MS will meet you where you are to connect, celebrate, and make a difference like never before. For more information, please visit walkms.org. You can connect with the National MS Society along with others affected by MS on Facebook, Instagram, Twitter, YouTube, and LinkedIn. I encourage you to like, subscribe, and make sure that you're on the Society's mailing list so you'll continue to receive the latest information on MS and updates on upcoming programs just like this one. And I'd like to especially thank Dr. Daniel Antoneda and Dr. Facolade. Let me say that again because I want to get names right. Facolade for joining us today. And I'd like to apologize if I haven't gotten those names entirely correct. And I'd like to thank everyone who's joined us for your great questions. Please remember that a recording of this webinar will be available at the Society's website at nationalmssociety.org/MSexpert, as well as on Facebook and YouTube. I hope you'll join us for next Friday's edition of Ask an MS Expert, where we're going to look at what's new in MS research. And now I have a favor to ask each of you. Getting your feedback on today's webinar is important. So you'll see a survey pop up in a moment when we close out the webinar. And if you're watching on Facebook Live, you'll see a link to that survey pinned to the comments section. And on YouTube, you'll find that link in the program description. Completing the survey makes a real difference. The information you provide helps us to continuously improve, and it helps shape future programs. The survey takes just 1 minute, so I hope you'll take a minute and please fill it out. On behalf of our guests, Dr. Daniel Antoneda and Dr. Falashade Focolade, and the National MS Society, I want to thank you once again for joining us. Please stay safe and make healthy choices.